Hi, everyone. Thank you so much for joining our Advances in Autism Research and Care webinar series. We're so excited to have you on this lovely Wednesday. Some housekeeping things on the little toolbar that's probably on the right side of your screen. There's a little questions pull down. If you want to type in any questions you have during or after the presentation, I can ask those with whatever time we have remaining. There's also a little chat function if you have any questions for me. Then feel free to type those in there as well. This will also be recorded, and the recording will be put up on our network YouTube page. So if you want to send this to any of your colleagues, I will be sending out a link to that following this presentation. Okay, without further ado, I would like to welcome our network medical director, Dr. Daniel Corey, who's going to be presenting our wonderful presenter.
Great, thanks very much, Megan. As everyone knows, the ARP has been devoted to improving medical care for individuals on the autism spectrum. And in addition to improving the care that is identified as best for them, we have a great interest in seeing that this care gets to underserved populations. Our speaker today is going to be talking about methods for reducing disparities in services and in identifying a specific program that she has been involved with her own research. Dr. Sandy Magana holds the professorship in autism and neurodevelopmental disabilities at the Steve Hicks School of Social Work at the University of Texas at Austin. Her research focuses on cultural context of families who care for persons with disabilities across the life course. Her work has been funded by the NIH and the National Institute on Disability, Independent Living, and Rehabilitation Research. And her current research is focused on identifying racial and ethnic disparities and evidence-based treatment for underserved children and families. She's involved in developing a program to train social work students on how to work with people with developmental disabilities and their families. And we're going to hear more about her work today. So I'm going to turn things over to Dr. Magana at this point.
Great. Thank you very much. I'm really excited to be able to speak to all of you today. I am going to talk about this project, Parents Taking Action, but I want to be able to bring in some of the elements of culturally tailoring interventions and how to think about those things as I'm talking. So I'm going to talk about a little bit about some of the disparities related to autism diagnosis and services. I won't do a thorough literature review on that, but just to give you some idea, especially in relationship to Latino families, which is what the intervention was designed for. And I'm going to go over some important elements for culturally tailoring interventions to think about. And then I'll talk about the intervention itself, Parents Taking Action, and how we did create a new intervention with cultural tailoring in mind and present some of the results and findings of that intervention. So first of all, if any of you are doing health disparities research, you may be familiar with this framework. This framework applies to health disparities research in general, could be related to health outcomes of the general population or specific populations, but we can think about it in relationship to autism. The first thing you want to do is first detect the disparities, and so there's been a good deal of research, but more needs to be done in that area within autism to look at defining specific populations and look at disparities within those populations in terms of health care, health outcomes, diagnosis, receipt of evidence-based treatments. Those are some of the areas that I think are being focused on right now. And so that research can look across race and ethnicity, SES, rural and urban groups, so different ways to look at that. Then the next phase is generally, and it's nice that this goes in a linear direction, but not always. Sometimes you go back and forth. But understanding why those disparities exist is the next phase. So once you detect the disparities, that doesn't really tell us why they exist. And so I know there's a lot of emerging research in our field on understanding some of the disparities that have been identified. So looking at the determinants of health and looking across levels, right? Because disparities can be at the individual family level, they could be at the clinical encounter level, provider level, or across the healthcare system. So there are all of those places that disparities could be happening, and really understanding those. You can use qualitative research as well as quantitative research to investigate the understanding piece. And then, of course, that gives us information and fuel to develop interventions to help reduce the disparities. And so, and again, interventions can be at all of those levels, at the individual family level, at the provider level, and at the policy level. And I think really to reduce disparities, you need to focus on, there needs to be some focus on all three levels. Not every researcher will focus on all those levels, but I think that it's important to have research on all those levels going on at the same time if possible. So in terms of the population that I am generally working with, looking at Latino families, one of the reasons I focus on Latino families is, I am from that background, and so I'm very interested in understanding how, from the beginning, how Latino families deal with having a child with a disability or an adult or any kind of family member. Latinos are one of the largest and fastest growing populations in the U.S., of course. And so the research is showing right now, looking at the latest CDC studies, that there are significantly lower rates of diagnosis compared to non-Latino white families. And so the most recent CDC study shows that 1 out of every 59 children have a diagnosis of autism, whereas among Latinos it's 1 in 71. And so the gap has been, since they've been doing these surveillance studies since 2002, the gap has been narrowing a bit, but it's still a significant gap. There has been a gap with African Americans as well, but that has narrowed a little bit more recently. But we also see a fast increase in prevalence. So we are getting better at identifying groups, but I think it really varies by region and by area as well. So that's something we have to consider and take a look at. But the other issue is that once children are diagnosed, there are significant disparities in children being able to receive the important specialty services that have evidence base, and also in quality and access to healthcare. So I've done some of that research looking at national data and finding disparities in healthcare quality and healthcare utilization, particularly between African American and white and Latino and white families. And then more specifically, and I think we need more research on this, but are the Latino children, African American children getting ABA and other evidence-based treatments at the same rates as white children? So that's a question that needs further exploration, but the current evidence we have shows that there are disparities there. And so just to show a graphic depiction of the CDC differences in terms of identification, and I'm sure in this network people know that identification, or when you're talking about the CDC surveillance studies, it's not real prevalence. It's more about prevalence of diagnosis, right? So to what extent the children had access to diagnosis, and in the more developed places, like the places many of you are working at, where they have really good professionals that are trained in how to diagnose autism. So getting access to those resources is a challenge, and I think that's a big barrier to evening out the identification rates. And then again, once disparities are diagnosed, their receipt of ABA and other evidence-based treatments is much lower. And they're also, racial ethnic minorities tend to be diagnosed later too, so that's another problem that we need to document, but also understand the reasons for and address. So we're thinking about understanding disparities for Latino families. There's been a lot of emerging research on that topic. I've seen some really good qualitative studies being done to really get at that, either in focus groups or individual interviews. But one thing that comes up, that stands out, is a lack of information and misinformation. And if you're talking about Latino immigrant families, which is who we did focus on for this intervention, they may be coming, the parents themselves may be immigrants, but the children are likely to be citizens if they're young children, and so they're eligible for all of the services, but the parents are coming from a country maybe that doesn't have a lot of resources to put into detection and awareness about autism, so they may know nothing about autism. In fact, we did a study recently that compared Latino immigrant families to white families and found that the Latino families, when they got diagnosed, their child got diagnosed, that was the first time they heard the word autism. And then it's a whole journey from there on figuring out what this is, going through all the emotions and so on. Whereas many of the white families, who were middle class families, tended to expect the diagnosis and feel a little bit relieved, because they had been trying to get their child evaluated. So that's a whole different journey that they had. And so, they've been telling their doctors, my child might have autism, and in some cases the doctors will not agree. And so when they get that diagnosis, sometimes they experience some relief. So there's some big differences in terms of information and knowledge about autism. And then navigating the service systems. This is something that I'm sure all the groups in the network are really dealing with a lot, because it's very complicated. So for low-income families or families who are immigrants coming to a system and trying to figure out how do you get to, that clinic that diagnoses autism, or how do you get eligible for certain Medicaid waiver programs that will pay for your ABA therapy, and all of that is very complicated. So that presents a lot of barriers. And, in general, in the service system, there are many barriers created just by the way the systems are set up. Language barriers, of course, and that goes on both ends, not just the individuals who speak a different language, but the fact that providers don't speak that language. So that speaks to the fact that providers and agencies can overcome these barriers by having staff that speak different languages. Immigration issues presents new challenges for many Latino families and other immigrant families, where there may be multiple immigrant statuses within a family. And so even if the child is a citizen, if the parents are not, they may be reluctant to seek services, for fear of being reported. And then, of course, there's at the provider level, there can be some bias or lack of cultural competency among providers, which contributes to all of these issues. So I'm going to move to the issue of addressing disparities. So once we understand something about why the disparities exist, we want to take that evidence and use it to developing interventions. And so I want to just talk through some best practices. Of course, there are many more that I won't have time to mention, but some things that we can think about in relationship to our practice. And it should be noted that I'm not going to talk about policy level interventions here, but that is important too. It's important that we're thinking about those, and also interventions that provide training to providers to reduce disparities. And, I have some colleagues who are doing that, and so that's very important as well. So first of all, if you're going to tailor an intervention or create an intervention for a particular cultural group, it's important to involve stakeholders. I mean, that's seems to be pretty well understood now. I mean, I think most people are doing this sort of thing, but bringing in not just the professionals and other folks related to the intervention you're talking about, but also families that come from the cultural group that you're representing. So listening to their perspectives and what they are going to respond to is very important. So having stakeholders is an important thing. Another thing that I'm sure many groups in the network are using are either Navigators or peer support of some form, and these are really good practices to reach different cultural groups. I will say about the peer support, generally you want to have peers who are from that community, right, and speak the same language. They're not necessarily professionals. They can be lay people, but receive extra training to be able to address a particular issue that the intervention's involved in. Versus navigators who can be peers, but also I've seen navigators also be professionals, so it depends on how you want to use them. But again, navigators are going to be very helpful in navigating those complex systems. And I bet many of you are using some of these elements. I'd be interested to hear about that. Then you get to the issue of adapting and translating materials. And this is something that it's sort of a basic thing that most people think about. Well, of course you have to translate materials. And even, agencies translating materials makes a huge, huge difference, even if you don't adapt them. But adaptation is important to consider as well. So you're thinking about not just a direct translation, but how do you address the cultural issues. And so if you're thinking about an intervention protocol, it's important to consider sort of the structure of that intervention. Is the length of the intervention going to work? Does it need to be shortened or conducted in a different way? Cost, obviously. Making sure the materials are engaging and minimize text and visuals, and especially if you're dealing with a population that has a low literacy rate or lower levels of education, you want to consider those things. And then making sure there's culturally relevant themes in there and that people can see themselves in the intervention. Family activities. We like to use stories too that reflect the group that you're working with to kind of give examples of the issues that we might talk about. And then, of course, there's accessibility, reducing the effort of families to have to be able to get to that intervention. And so thinking about where families live. Right now I'm in Austin. This is my second year here, so I'm exploring all the resources in the area. And, I'm finding that, for example, ABA therapy, first of all, Medicaid doesn't pay for ABA therapy, so that cuts out a whole portion of the population that cannot, or low-income families that cannot access that. But the ABA providers are in Austin is divided into East Side, low income, West Side, high income. It's very segregated, and so the ABA providers are all on the West Side, and so that's a challenge. But I mean, some of them are making an effort to do home visits and things like that, so it's a way to overcome that issue. Being close to public transportation, making sure that if you're having people come in for groups or wait long periods of time, that there's childcare and snacks. And then if you're doing group interventions, having smaller groups to promote discussion. So those are some of the considerations, and I'm sure many of you have other things that you tried that have worked really well. So I'm going to move on to describing the intervention that we developed using some of those elements. PTA, or Parents Taking Action, we call it PTA, is what we developed. And so we did, in our initial development of this intervention, focus on Latino immigrant families because of the disparities that are there. And so we wanted to address things like the lack of information that families have, limited knowledge that they have about autism itself and ASD, so sort of providing that psychoeducation. We wanted to make sure that it was delivered in a way that considered culture and language and addressed their needs and preferences and learning styles as well. And we wanted to make sure to overcome obstacles like transportation and childcare, things like that. And because of these different elements, we believe that PTA is relevant for other low-resource families, not just Latino immigrant families. And at the end, I'll tell you a little bit about some areas where we're working with other groups to expand who PTA is working with. And so in this intervention, we were using the Promotora model. Some of you are familiar with Promotoras, and I'll explain a little more about that in a few minutes. Tried to use a community-based approach, so again, engaging stakeholders. We used a framework that I'll show you called the Ecological Validity framework to think about how we were going to create the elements of the intervention. And then we really tried to use an empowerment and self-efficacy approach. So we did form an advisory committee, thinking about the stakeholders. We actually did our first pilot study was when I was at University of Wisconsin, and so we did this in Milwaukee. And so in Milwaukee, we involved an organization. It was a parent training information center that it does a really good job working with Latino families in Wisconsin, and so they were our community partner. And they came to our attention because one of the people who is a staff member in the organization is a Latina and a parent of a child with autism, and so she really connected with us about, developing this idea. We also included professionals, so we had a pediatrician and a social worker who were both bilingual and working with the Latino communities there, and of course we included Spanish-speaking Latino parents in the group to advise us. And Emily Island is a parent as well who does a lot of consulting on autism and parent education. So what we did is we met several times with the group so that they could give us feedback on the program content as we were developing it. So in this case, we were actually developing content, from the literature and from evidence-based information that's already out there. This is the Ecological Validity framework for cultural adaptation. And this, so what we did is we asked our advisory committee to sort of consider these dimensions as we were presenting different content and information. And so I'm not going to go through each one of these, but these are really good dimensions to think about if you're adapting an intervention or creating a new one. So you want to, of course, consider language, persons who's delivering the intervention, using, common sayings and metaphors that are used in that culture. So bringing in some of those cultural issues, bringing in cultural values in the content, and making sure goals are going to be realistic for the sociocultural context, and making sure your methods are flexible enough for families, and taking into consideration context. In this case, we used a home visit model, which overcame some of the barriers like transportation and childcare. So this is our curriculum, and just to give you an idea of the curriculum, when we first developed the pilot study, we did it in 2 modules. But then when we were developing our randomized trial, we put it all together in one package because it's hard to test 2 modules in a randomized trial. And so the first part of the intervention is really focused on that psychoeducation. So understanding autism, what does the DSM say about autism symptoms and how does that play out in your child? Understanding the even child development issues related to social communication. And then what works to address autism is really about what is evidence-based treatment, what treatments show evidence, what treatments don't have any evidence, and really trying to get parents up to date on that information, and then using that information to move into advocacy. So now we know what treatments our child needs and services that they need. So how do we advocate for them in the community and in the school system? Then our next few sessions really move into evidence-based strategies that they can use with their child. Now, in this intervention, we didn't do coaching with the parent and child. It was just parent education. So oftentimes the parent and the community health worker or promotora met together during school time when the child was at school. unless they were a young child and they might be home. So yeah, this is the remainder of our information. Wendy Mihalacek, who's a BCBA, really helped us develop a lot of the information around strategies and challenging behaviors. But we also wanted to make sure we're talking about stress and how to recognize it and reduce it. And then talking about autism to other people, developing social support. So really trying to get in some information for the parents themselves was important. And so just to tell you a little more about the Promotora model, for those of you, many of you are probably familiar with Promotoras, especially in public health. It's used very widely. I actually first learned about Promotoras in Texas when I was doing a class bringing students from Wisconsin to the border, and we found that the public health center down there used Promotoras, so I really wanted to find out what do they do. And so in public health, Promotoras do a lot of education about chronic health conditions or awareness campaigns, so they could be used in awareness or in direct education. There were some Promotoras at the center that were working with researchers on a psychoeducational program on mental health, and so the idea is that they learn a particular curriculum. If it's going to be on education, they might learn the curriculum, and then they would be the ones to deliver that curriculum. In our case, we recruited parents who were we want to make sure they were parents of children with autism, because we wanted them to have that shared experience of being a parent versus somebody from the community that really had no knowledge about autism. And so that was a criteria for our Promotoras, that they be a parent. But then we also wanted to make sure they were leaders in the community in some way. And so we worked with community organizations. In Chicago, for example, there was a large support group, and there were parent leaders in that group, and so we invited them to think about being a Promotora, because you want them to be people who are already thinking about helping other people, maybe already have settled some of the issues with their own child. They're not struggling with that at the moment. So that's the Promotora model that we decided to adopt, but some people you can call it a peer leader or any number of different words. So these are our Promotoras from Chicago, and they worked with us on this project for several years. There's a cake there because they had just finished their training, and you have to celebrate when people go through a program. And many of these moms, they were so great, and they stayed with the program for a number of years. We also had a site in California, and so these were the California Promotoras. And so again, they were really great as well. In terms of thinking about the training, so we did pretty extensive training with the Promotoras. We did 32 hours of training, really going through the curriculum, doing role playing, a lot of having them deliver the material in different ways, and so it was pretty intense, but important that they get that training. So it was almost like receiving the intervention in a group level, because we did the training in groups. It was very interactive, and then they were set, hopefully. And then we developed some materials. So we had a manual for the Promotoras. So that manual has a little more instruction for them on what to say and what to do. And then we had a participant manual, so all the families who participated received a manual with the main content in there. We tried to create some videos that would go with the manual, so the Promotora would carry, in this case we used old school. We used a little DVD player. That they brought a DVD, and then they played the videos that were either a story about a particular concept we were talking about, or and towards the end, we had some videos of a parent and child using some of the strategies, or just somebody delivering some content just to break up the activities a little bit. And there are different activities in there. There are resources that we gave the families. So we gave them all a folder with local information about, different services for their children and for themselves. some information about broad issues like depression for themselves, just a lot of resources in there. We also, when we talked about things like visual schedules and token economies, things like that, we actually gave them laminated materials that they could use and keep. So now I'm going to move to talking about the study that we did. So we did the pilot study in Wisconsin, and then we received funding when I was in Chicago at UIC to do a randomized trial. And this study, Wendy Mihalacek was involved as a co-investigator, as well as Christina Lopez, who's now at the University of Arizona State. Christina's at Arizona State, and Wendy is at University of Oregon. So our criteria was that the families, the parents be of Latin American descent and have a child between 2 and 8 years old. And the content is ideal for parents of children who were just diagnosed, but we recognize that a lot of these parents that we found in Chicago weren't getting diagnosed till they were in school, the children, until like 5 or 6 years old. So we wanted to make sure to include those families. So we did screening, making sure that the child was either had a diagnosis of autism or screened on the MCHAT or another screener that they were at risk for autism. So we even included some families where the child was at risk, although the majority of families in our study, they actually had a diagnosis. And then they were randomized to, after baseline assessment, they were randomized to receive the intervention now or later, which was in 8 months. So we did 3 time points of data collection, baseline, 4 months later when intervention was over, and then 4 months after that. And then people who wanted to receive the intervention in the control group, we offered that to them. So just to look at our demographics of the people in the study, so we had 55 in the intervention group and 55 in the control group across California and Chicago. Majority were in Chicago. And the only thing that you can see who the population is. I mean, the parents are mostly immigrant family parents, foreign born. Majority were married. The average age of the moms were around 37. Average age of the child was around 5 years old. And majority male, as you would expect. They had about the same level of severity in terms of symptoms. The one thing that was different was education level, where the intervention group were more likely to have a high school degree or more. And so that's something we controlled for as we did our analysis. These are our measures that we looked at. So one of the measures was number of services, because we're trying to empower parents to increase the number of evidence-based services that their children are getting. So that was one of the outcomes. We used the social communication questionnaire as an outcome, and we used the scales of independent behavior to look at challenging behavior. And to be honest with you, our main focus in terms of outcomes were parents, so I'll tell you a little bit about the parent outcome measures. We didn't expect that we would have child outcome changes, just because we know the research shows you have to have intensive therapy to be able to have child outcomes, but I'll tell you about that later too. So our parent outcomes, we used the family outcome survey, which was developed by Don Bailey, and really has kind of empowerment-oriented items and subscales around like parents understanding their child's needs, knowing their child's rights, knowing how to help their child develop and learn. Those kinds of items were in that. And then we developed a measure called efficacy in using strategies. So that was basically how confident did parents feel in using the evidence-based strategies we were teaching them. So we had, I believe that was around 14 items that we had there. It was a Likert scale. And then we have a measure of frequency using strategies. So that's the self-reported measure of how often they're using the evidence-based strategies. Similar Likert structure. So those were our outcomes, because the main focus of the intervention was to get parents to use evidence-based strategies, as well as empower them to get more services. So looking at child outcomes, we were actually surprised by this. We had a reduction in the social communication impairments on the social communication questionnaire in the intervention group compared to the control, and that was a significant difference. So it did have some impact on the children. We didn't find differences in the challenging behavior measure, however, and so that's something that did not have an effect. We did find an increase in evidence-based services. So children in their intervention group were receiving at least one more service, evidence-based service, than they were before, and compared to the control group. So that was in the direction we wanted to see in terms of reducing disparities. Maternal outcomes, the family outcome scale was not significant for the parents, so we did see an increase in that for the intervention group, but also an increase for the control group, so that made it not a significant difference. But when we looked by site, we did see that California, the California subsample did have improvements for the intervention compared to the control in this overall scale and in all the different subscales that it had. So we're not exactly sure why in one region it worked better than in another region. So that's something we're exploring. But we did find that across both sides, the efficacy and use of strategies. So parents were reporting that they felt more confident in using the strategies we were teaching compared to the control. And then frequency and use of strategies, and this was a significant difference as well, where parents were reporting more frequent use of the strategies. And this is a self-report measure. We also did some 10-minute observations pre and post and across the different time points, but we haven't analyzed all of that data yet. So hopefully that's forthcoming, and we'll get a better understanding of whether it matches these findings. So overall, let's see, am I doing okay on time? Overall, we found that there's some good value, promising results in terms of having impact on parent outcomes and even some on child outcomes for this intervention. So we increased efficacy and parents developing their skills working with their children. There are some limitations, of course. It was a decent enough sample size to have statistical results, but maybe not enough to be representative of many different groups. And it was mostly immigrant moms who were of Mexican descent. We did have some other Latino groups in there, but mostly Mexican immigrants. All measures were self-report, so that's a limitation. And we're now working on actually taking some of this content and trying to introduce the coaching, parent-child coaching of evidence-based strategies, social communication strategies, borrowing from some other interventions that are existing, but trying to adapt them in a way that is more accessible for Latino parents. So we think that would really strengthen the results as well. We have been doing some dissemination. We have a group at the University of California, San Diego, who were addressing a call from the regional center in California. There's been some analysis of their data showing big disparities, racial ethnic disparities, and particularly between Latino and white people with IDD in their system and expenditures. And so they were able to obtain a grant from the regional center to try parents taking action there. And they actually adapted it to be for an older group, because that was the age, it was an older age group like 8 to 13 where the disparities were being recognized, and they also adapted it to go across IDD, not just autism, because a lot of the topics we talk about are very relevant to other children with IDD. So they're currently working on that project. ASU, so Christina Lopez is doing a project right now with the Southwest Autism Research and Resource Center, where they're doing some, I think they're introducing this with pivotal response training and trying to see if a merged model would be effective. And then we did a train the trainer program with 4 community organizations across the country. So Indiana, Washington, North and South Carolina, and they learned how to implement the program. And currently we have a group with Sarah DeBotna, who is they just finished doing an adaptation for African American families, and they've started the program right now. So it'll be very interesting to see what adaptations they end up making, but then also how it works for them. And they're using African American parents to be the community health workers or the peer leaders. We also tried this in Colombia. So I was able to connect with a partner there who really wanted to address some of the issues in Bogota, where there's just limited resources for families. And so not only was it fun to go to Bogota, but also my partner there, she was at the National University of Bogota in Colombia, and she was so well organized. I mean, everything went really as planned, which doesn't always happen when you do international work. And so it was great. But what we did is we randomized we had 20 families, and we randomized to 2 groups. One was using parent promotoras, and the other was using student promotoras, because my colleague felt like parent promotoras really weren't capable of doing it, and that it should be professionals, and that was sort of the general, parents wanted to look to professionals to provide service, not other parents. So that's a cultural difference that we were addressing. So we decided to compromise and see, well, how does it work for each of these? And it was interesting because the student promotoras did really well. In both groups, there was improvement, but I think there was more improvement with the student promotoras. So my colleague was right, I have to admit, in that case. And so that's those are all the different collaborators that we've had and the different sources of funding for the project. And I believe that is it. So I'm happy to take questions or.
Great. Thanks very much. That was a wonderful presentation, Dr. Magana. Megan, have we opened up the microphones? Do we have any questions or comments from our audience? Megan? I'm not able to see if there are any questions or comments or hands raised, so I am not able to see what's going on here.
I wonder if Megan's on mute, maybe.
Well, she is on mute. I'm going to text her here.
Yeah.
So while we're waiting to see if there are other comments from folks, I really enjoyed your presentation. We had used the Promotora model at our Arkansas site a few years ago, and was another very successful endeavor there. It was very well received with the community. It's interesting. I had not heard of trying different types of promotoras. Ours there was all parents, but the idea of using students made me think of other studies that have worked with, for example, um, lay home visitors versus nursing home visitors, the difference between a professional and an interested adult, but who is not necessarily a professional. And so there are some differences there. Do you feel like there are any advantages to one over the other than your experience in Colombia, in terms of funding or getting a program started in a community?
That's a really good question. Because we did pay the promotoras for their time, and it's not a huge expense, but it is something like a community organization that wants to implement this has to take into account, right, to be able to get some funding to pay the community health workers. Whereas if they have some staff already on hand, it might be easier for them to implement. So that's one of the issues, I think, in working with the 4 community organizations that we ran into. And I had a student come visit me over the summer who did, she wants to do her dissertation in this area, and she did some group sessions here in Austin, where she delivered a lot of the content from PTA herself. And she was such a relatable person. The parents just loved her, and so it worked out well. For her, she was from Colombia. Her first language was Spanish. And so parents really related to her well. One of the things that we're going to try here in Austin as well is we're working with different groups like the Autism Society and the New Dell Medical School and the school district. And we are going to try to do this in groups, but we're going to have a student leader and a parent leader. So kind of that might be the best mix, right? So you have a pair who are facilitating the groups, because the parents in the focus groups that we did in the United States, they really valued that parent-peer relationship, having that shared experience and being able to share stories. They really got a lot out of that. So I hate to lose that piece. And so maybe by having a pair, because in some cases it is easier to get students. They can do internships and projects, and it might be easier to get them to do these roles. But I think we need to include the parents too.
Yeah, I think that looking at mixed models like that and seeing if there are some other advantages. And of course, one advantage is the training of the students so that we can further disseminate this kind of a model to other communities is something to think about as well. Megan is there. She is having a lot of difficulty unmuting herself, but she is unmuted the audience. So if you want to click the hand raise icon, she can unmute you, and then you'll be able to ask a question. So, and I can't see if you're raising your hand because I don't see the list of attendees, but keep an eye on your screen, and she will, if you raise your hand and have a question, she will unmute you, and then you'll be able to ask it. Getting back to the navigating issue, one of the things that we also did in the network with the current cycle of funding, we required all of our sites to have a family navigator, which is a different spin on case management or case coordination. It takes it the next step. In general, family navigators tend to have a much closer tie with the families. They themselves are often parents, and the way that we have implemented this across the network is that we do have in some sites the family navigator is a parent of a child on the spectrum. In other sites, it may be a professional, a nurse or a social worker. So we've got a mix, and we are in the process of looking at the results from this mixed model. Each network site did this as it fit their funding capacity and their community, and so it's been an interesting trial. We're hoping to see, again, come up with some good recommendations for solutions for sites in improving the care.
Wow, that sounds really great. Yeah, that's really neat that you guys are doing that. I was thinking with the navigators, yeah, I mean, I think that having a professional or a parent, I mean, there's strengths that each of them have, right, that the other doesn't have. And so, I think having both. One of the things about working with parents too, I found it's really important to, like when we had parent promotoras, we didn't employ them as, as staff members because they didn't have that much time to dedicate to it. Like we would give them one family at a time, or some of them could handle two or three, but we really structured it so that they could decide how many families they would serve. So if they took one family, they're going to see that family for 14 visits once a week. If they have two families, that's 2 meetings a week that they would have. So really taking into account their time because they have their own children. Sometimes they work jobs, all of that, and then making sure to compensate them for their time. And so depending on the organization, sometimes they were paid on an hourly basis, or sometimes they were given a stipend for completing an entire family set of visits.
Mhm. So I do have a question here in the chat box. I don't know who sent this, but going back to the issue you mentioned regarding families with various immigration and citizenship status and their concerns about seeking out services, did you come across this issue in this work? And if so, how did you address it? Did you find that this was having a significant impact on your ability to reach these families?
I think that, I can't say that it came up like even in Chicago or California at the time we were doing this, but it might have come up in the home visits with the families. But I feel like the biggest issue that we found with the immigrant parents, like when we did focus groups, was just stating, I didn't even know I had a right to ask for this. And so it wasn't even the immigration issue. It was more like they didn't think their child had any rights. And I think having this is where the parent navigator really helps, because they're the ones that are already accessing services, and so they can give them specific strategies on how to do it and how to avoid certain issues or problems that they may run across. But I didn't hear any reports of specific
Okay.
issues in this project.
Okay. Another question we have here, were there any concerns about liability insurance for or liability for the promotores? And if so, how was that handled?
That's a really good question that I'm not sure we handled very well. Maybe we were just really lucky. But I think it depends. Like if some organizations that did try it, they have liability for their employees, and so if they treated them as an employee, then they would get the same coverage. If it was a nonprofit organization, like in Chicago, we worked with a group called Grupo Salto, and we gave them a subcontract, and then they paid the promotoras. And so I don't know how they dealt with liability issues. If their university was paying them directly, obviously the university is going to be liable. They may not like that, but I mean, you're liable for your students who go out and do internships as well. So, I mean it's an issue that I think we probably didn't study hard enough about, but didn't run into any major problems, luckily.
I've got a pair of questions that sort of go together. Are you able to share any of the materials from your intervention? And is the manual that the promotores used available to people?
What we've been doing is we're open to having people contact us if they're interested in implementing it, and then figuring out how we can do sort of a train the trainer program. So in some cases, we've been able to visit particular sites and provide the training, like, basically to give them an understanding of how do you set up this program, how do you train your promotoras, all of that. We did an online webinar training as well. So we're trying to explore that aspect, but we want to make sure that we're not just handing out the materials, but that people are getting some training in how to use them. And so yes, please contact me if you're interested, and we can figure that out, how to distribute that. One of the things we're trying to do in Texas, we're applying for funding so that we could not only do this group model, but also maybe create an online class using the material. And so that's something that could be available anywhere.
That sounds great. Another question here. Can you talk about the oversight of the promotores? How were they supported and supervised in their work?
That's a really important thing, yes. So monitoring fidelity. What we did is we had a fidelity checklist, and we also, once the promotores, they got trained and they went out and started to do some visits, then we tried to bring them all back together to share their experiences and bring up any issues and problems. But then we also had some of our team do observation visits, but not for every session. Just like out of the 14 sessions, maybe we would have 2 observation visits for every promotora using the fidelity checklist. And then we would have the promotoras fill out the checklist themselves after every visit. So we did some monitoring that way. And then also we had a coordinator. So this is really key, having somebody who coordinated the work of the promotoras. So the promotoras would, after each home visit, call the coordinator and let them know if the visit went okay, if it was canceled, what happened, if they had any questions they couldn't answer. So that was another factor that we included.
Very good. One final question. Would it be okay if Megan sent around your slides with your email attached so that people would be able to reach you and continue the conversation?
Yes, absolutely.
Excellent. Of course, as we mentioned at the beginning, this webinar is being recorded and it will be posted on our YouTube channel, but it usually takes a couple of weeks before we get that posted. But Megan will send that the slides around with Dr. Magaña's email on that so that you can reach out to her and see if we can continue this or get this sort of a program going at your own sites. We have reached the end of the hour. I want to thank Dr. Magaña for a wonderful presentation. It certainly sparked a lot of questions and discussion here. I want to thank everybody for hanging on through the technical glitches, and Megan for her resourcefulness in forwarding the questions to me through the chat box. And I hope that everybody has a wonderful rest of your week. Thanks very much, folks. Bye now.
Bye-bye.